You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. Today, I'm joined by Dr. Matthew Trowbridge, a physician, public health researcher, and longtime leader at the intersection of design, technology, and health. We explore how the spaces we create, from exam rooms to emergency departments to entire neighborhoods, quietly but powerfully shape behavior, clinical outcomes, and even joy in practice. Dr. Trowbridge shares lessons from his work, including how small design choices can boost patient experience, improve safety, and help clinicians reclaim time and attention. For healthcare system leaders and physician executives, this conversation offers a provocative reminder. Environment isn't overhead, it's strategy. Let's plug in. Dr. Matthew Trowbridge, where do we find you today?
Well, it's great to be here. I am in my home office here in Charlottesville, Virginia.
Welcome to the podcast. I'm pretty excited to have you here. When we were preparing for this, I think we went on and on and on for hours. And so there's a lot of stuff that you do that is going to be very interesting to our audience. So before we start, why don't you give us a little bit of a background? I assumed you were an emergency medicine doctor, and that was proven to not be true. So tell us what you do and how you got to where you are.
I'm a physician and a public health researcher, associate professor here at University of Virginia School of Medicine. I am well known for my work in the built environment and health. I think we'll get into that in our conversation. Fascinated with the way that the places we live in impact our health behaviors, health choices, and our health outcomes. And I've done a lot of work thinking about how to design interventions at the full stack to actually try to incentivize real estate for making healthy places. Really, genuinely, I've been inspired by the work I've done with designers over my career. And I've had a lot of fun trying to pass that on to medical students. So the other thing I'm proud of and get to do is I've been teaching a design thinking program here in the University of Virginia School of Medicine called the UVA Medical Design Program for about 10 years. Basically, if there's something going on at the intersection of health, design, and technology, I'm in. I genuinely believe that all the things happening in healthcare right now, those things, we need to be really thinking deeply about how to do things at that intersection. I was really fortunate to grow up in the 1980s Centers for Disease Control community. My dad was a physician, a pediatrician. He was really one of the original Epidemic Intelligence Service officers. So, in my youngest era, ages, we lived abroad in El Salvador and other parts of Central America while he was doing a global kind of child malnutrition work. And so we came back to Atlanta when he was served as the director for nutrition at the CDC for a long time. And basically, I happened to just grow up with these public health icons. I mean, it was very normal for me that for a physician, when you ask them what they do for a living, they would, if it was Jeff Copeland or Bill Foege, they would say, well, I work on eradicating smallpox. And my dad was focused on, iodizing salt in South America. I was like, okay, that's what a doctor does. Like you take on like a massive, massive issue at a global scale. And so I was like, that sounds really cool. Let's do it.
That is amazing. That is an unusual upbringing. So most of us don't have physicians as parents. But if we do, most of the time they're generally doing things that the vast majority of physicians do, which is I go to the clinic every day or go to the office and see patients. And then I sometimes go to the hospital and deliver babies or do operations. And that's what physicians do. But you had told me a story somewhere about, running through the halls of the CDC, which I suspect would be frowned upon nowadays.
Yeah, I'd have to kind of go back to a very different era of Clifton Road in Atlanta, where it really literally was like my mom would drop me off at the front door and I would run into my dad's office. And it's relevant even to my own career, is in the sense that, during medical school, I went to Emory. I literally was planning to just go right into the Centers for Disease Control. But, obviously with 9/11, the what Centers for Disease Control was about had to change and did change, and dramatically. And gosh, I was recently in Atlanta, and it's unrecognizable. Obviously, now you've got, it's obviously, it was always doing serious work, but it's a very different place now. But this was back when the Centers for Disease Control director was not a political position. It was often somebody who was started there, worked there, and kind of rose through the ranks. So it was a very different time.
And so you were always kind of planning on doing something in public health, right? That you got your MPH fairly soon.
I was one of the first combined MD, MPH students at Emory. And it turned out to be pivotal. This was in the late 90s. And I think about this all the time because, again, lucky, in my opinion, to grow up in the community I did. Then I did a 1-year master's in public health at Emory and took Environmental Health 101. And it just so happened that at that exact moment, some of the physicians that were really defining or bringing attention to the built environment as something that by every sense of the definition really should be treated as a public health determinant were there. So we had like Dr. Howard Frumpkin. He was the chair of environmental health at Emory at that moment. We had Richard Jackson was at the Centers for Disease Control, and people like these people are these iconic figures in the built environment and health space. And I also learned a really important lesson from them looking back is this was radical thinking at the time that was not happening anywhere. Built environment was not an established thing, but they taught us it was just included in the environmental health like syllabus as if it was 100%, and it worked. I just absorbed it because it held water. It was logically sound, and it was really interesting. But they just taught it as like, hey, chronic disease, biggest issue of our time. You know what? Actual causes of death, not heart disease. It's actually like lack of physical activity, poor diet. Guess what? Like there's a structural element of the way we're designing our lives, particularly in a place like Atlanta, where we're building car-dependent lifestyles. We're creating food deserts, and these are real. So environmental health is part of it. And we all kind of said, yes, sir, and absorbed it. And I'm like, gosh, that's powerful. I'm going to do that. And I've looked back and realized that was genius. And I'm trying my best to do the same thing with design.
I think it is genius. And it's kind of what makes me think of, the kind of fake it till you make it. They acted because they believed that this is a major part of health. And it was. They
also, all of them have such serious chops that within they were already actively building that evidence base. But it was, again, they so effectively brought in, people who were their students. I've had the incredible honor to go on and actually be colleagues and collaborator with all of them. That's the other thing I've learned about teaching is that like you blink and your student becomes your partner and your colleague. That's why I still continue to put a lot of energy and passion into teaching.
Probably a year or so ago, we had an architect who was also a physician. I think she calls herself a docitect, which I believe is copyrighted. So don't try and steal that. So when you're talking about built environment, you're talking to some extent about physical structures like an architect would, but it sounds like it's on a much bigger scale. So not just, hey, this is how your house is constructed or how a hospital room is constructed, but this is how the city is constructed.
That's right. Well, how about this? If you're a listener of this podcast and you're interested in design and health, let me just tell you this. You've got to just be brave because, yes, I think about the built environment very broadly. When I say what I do to my clinical colleagues, they hear built environment and health. Wow, that is such a niche thing, man. Well, then when I go into the rest of the world and I'm a complete generalist. Like, they bring in the MD to talk about the built environment. And sometimes I'm in a room speaking to urban planners or transportation planners. So I'm, in some ways that's where I'm most comfortable because that's where we're in the world of like data and statistics and coefficients. And it's very like, nerdy, kind of high level stuff. But I also get into things like architecture, or, okay, well, now you've got to take, our evidence and turn it into like really specific, design guidelines. And then even into things like, some of the stuff I think is most interesting is things like aesthetics and interior design. Like one of the most compelling things I ever heard was some work a consultant did for I won't name the brand, but like essentially like a salad prep, brand that part of what it does is it comes into rapidly gentrifying neighborhoods and has this really cool modern aesthetic and everything like that. The reality is, though, she came in and showed them like, I believe you're really trying to be equitable and really have like just fair things. But by the way, your aesthetic is not welcoming to a lot of people. And I think that's so interesting, even thinking about like, okay, just because it might make it, you can make whatever choice you want as a business, but just know that like, however whatever design you put out there, it impacts people, and it impacts the way they react to you. It impacts the way they act in that space, or even how they feel, if they're welcome in that space. It's kept my attention, this whole built environment thing, for so long, because you can never be an expert in all of it. And again, because I'm a doctor, I get invited into rooms as the interesting person that I really have no business even being in, which is great. So, I try to bring some value when I can.
These aspects of design that a lot of people don't consider. I was talking to someone who's responsible for operations at a hospital, and we recorded this podcast, hasn't come out yet, but he put sound level detectors around the hospital. So not picking up a voice or recording what people are saying, but just what is the decibel? How loud is it? And just was looking for outliers, and noticed there was one area right near a patient's room where it was regularly louder than it probably should have been. And did some actual field work. And by that, I mean, walked over to where this detector was and found that it was near the nurses' station. Upon further investigation, found that, well, nurses, this is where they often did sign out to one another. It's kind of those things you don't often think about.
Yes. And in fact, I got to do a really fascinating thing a few years ago. I took a sabbatical from UVA, and I actually served as the chief medical officer for a building certification system called WELL, which is the company's International Well Building Institute. And, they have a very robust, like many hundreds of strategies, system. It's similar to LEED, but for health. And to your point, it covers about 10 different concepts, as they call it, all of them evidence-based. And they range from everything from, like, as you said, sound to light to, promoting physical activity, to the materials and like very deterministic aspects of interior air and stuff like that. So there's so much evidence out there. And in certain areas, like where there's a high incentivized structure, so like commercial real estate, there's starting to be really clear evidence that like people, if they can have it, they would like to know that they're in a as healthy a space as possible. Strangely, in healthcare, we have all kinds of regulations around things, but we really are not using like a fraction of the available evidence beyond just pure safety, or things like nosocomial infections and stuff like that. There's so much more we could be doing. And then we get stuck a little bit in the idea of like, there's such a demand on space and throughput and so forth that unfortunately I think design sometimes turns into care efficiency metrics only, like 8 rooms, as opposed to, well, all those rooms are not the same. Like some of them are loud, some of them are hot, some of them. And yeah, that's the other thing that keeps me going with this work, is that there's just kind of unlimited ability. There's opportunity just to apply what we already know, just better.
Yeah. I love your idea, that concept of adding friction. Efficiency is great for some things, but sometimes we actually want things to be a little bit slower, and adding some friction points are good. There was an article that I love to cite about a chair. Oftentimes in a hospital, there's a chair for a patient's family or friends, and it might be out, but it's often folded and either hanging on the wall or in a closet. And someone did a study whereby they took the chair out and just put it right next to the patient's bed. And then they told physicians that they were going to be observing the physicians, their interactions with the patients, of course, with the patient's approval. And they made up some reason, but it really wasn't the reason that they wanted to study. What they wanted to study was, how long was the doctor going to stay in the room? Did they sit down in the chair? And what were the patient's perceptions of that interaction? And what they found is their HCAHPS score went up significantly in terms of patient satisfaction. And, what did they do to get their HCAHPS score up? They put a chair there. Did they tell the doctors, hey, we really want you to sit down because we know that when you're standing versus sitting, when you're sitting now, you're at the level of the patient, and patients perceive that better, and you slow down a little bit. You're a little bit more, at least the perception is that you're more caring and not in a rushed way. And no one told the doctors anything, but the doctors are like, oh, there's a chair, I should sit in it. And they just did, right? And to me, like, that's a little bit of friction. Like, yeah, it's much more efficient. I can get them in and out of that room faster, but boy, an extra 1 or 2 minutes, pretty good.
Okay, well, we're trading fun quotes. I think one of my favorite ones from this realm that always stuck with me is, why should we care about architecture? Well, how the quote goes is that architecture reflects the ideals and values of a moment, but then persists for decades, even centuries. And so I think, in healthcare, think about that. So I think it ups the stakes when you think about it that way. We all can think about, like, when you design a new emergency department, like we did in UVA a couple of years ago, you really should think about, like, what it is, like you said, like, what are the values and the behaviors of this moment? Be very careful, because it will set the tone for the next 20, 30 years, probably, until you get another chance to design it. The one I took my design students, we did a lot of, like, small scale interactions with the building when they were designing it and building it. We went into the old emergency department that had been built in the 80s during managed care. And guess what? It was like this I actually think maybe purposefully not very nice, like, place. I think the aesthetic was, don't hang out here, get out of here. They were aghast at was how few electrical outlets there were for cell phones. And I was like, well, those didn't exist when this emergency department thing. So another thing of kind of like not being forward looking, not recognizing that you're building something in a moment that will likely change. Like our emergency department was designed during, like, the Obama administration, and then it finally got built, like, right in the middle of COVID. It's like, it's hard to do this, but the infrastructure we build is so much more important than we realize. And we in healthcare, I think we tend to think of it very just cost per unit, square footage, whereas I think there's a lot more going on.
It's not just how many patients can we get in this, square footage, and there's so many other things. And as you pointed out, hospitals are not only being judged on some of these other characteristics like quality and patient satisfaction, they're being paid on those things as well. And so it's super important. So tell us about the medical design program.
I really had this privilege of working with all these architects as I was kind of getting more and more, I'd kind of got into the built environment space. Not a lot of people were working at it at the time. So I did some early publications. I had this amazing opportunity where I actually because I was kind of operating in my own lane, I was actually brought up to NIH. I got to work with the National Cancer Institute and their obesity prevention group. And they were interested in the idea of things like optimizing school design to promote childhood obesity prevention. And what I pitched them on was, you've got all these great programs that are really well, the programmatic elements are really well evidenced, but you're treating the school facilities as a commodity. And I don't think that's actually true. So what was cool about it was we kind of leveraged into the idea of, like, what would an optimal school environment look like from the perspective of, if we think we have some software, like great school-based obesity prevention programming, what would be the optimal hardware for that to run? And so it was things like, okay, well, long-term food attitudes, to fresh foods. Okay, cool. Well, what should the what should the cafeteria look like? How can we make the kitchen more functionally ready for scratch cooking? And importantly, how could we do it in a way that was actually feasible to actually do in a project? And I just thought it was fantastic. I learned so much I had some brave architecture firms that signed up to kind of listen to me talk about the public health evidence. And then they taught me how to translate that into like actual spatial intervention. Eventually I was just like, I feel like we should teach this to medical students. I'm learning a lot. I think this is actually particularly in like hypothesis generation, or like, I think this is turning me into a better researcher, all kinds of things. And suddenly I realized like, wow, they've been teaching design thinking in business school, including University of Virginia, for like 10 years. I've always found a lot of success if you're proposing in healthcare or in a school of medicine style of bureaucracy. It's often better in my experience not to be doing something brand new, but more saying, I'm adapting, and you get to say these really great academic words. I'm adapting an existing pedagogy to a new use case. By the time they figure out what you just said, they've already said yes, and you're off to the races. All kidding aside, that is how it started. But what I actually pitched them on was, hey, let's look at the AAMC, competencies for future physicians, and this was a fairly recent, kind of revamp of it. And it included things like systems thinking, tolerance of ambiguity, the ability to work in interdisciplinary team. The word empathy was written everywhere, and I was like, these are great. How are we doing on them? And they were like, not great. I was like, does anyone really know how to teach empathy? No, but we know it's important. Great. Maybe there are some frameworks out there that address these things directly. And I said, oh, here's one. Design thinking. I don't know about that. Let's look at this together. And actually, Darden School of Business here at UVA is a world leader in design thinking and business. This is cool. You know what? Maybe this is our thing. We're a little behind, but maybe we can catch up. So suddenly design thinking was a catch up for the people not seeing me. I'm whispering into the microphone, which is kind of design, user-centered design, find a pain point that somebody cares about and start from that, right? And instead of driving design down their throats. And there's a growing number of us trying to teach these courses across the US. So something I really deeply enjoy. I hope you can hear that in my voice. It's a pleasure to talk about.
It's amazing. As physicians, as clinicians, just in general, the ability to kind of learn the language of a different group of people. In my world, it's often been technical people. Some of the EHR vendors have started these programs called physician builder programs, where they'll take practicing physicians and give them just a smidge of knowledge about how the electronic health record or other technology works underneath the hood. Are they competent to do a bunch of things by themselves? Absolutely not. They're competent to do a few things, but not a lot of things. But what I really think is impressive and been helpful is that they now have a language that they can use to talk with the more technical people. And then, like the architect or the designer, oh, I know what to draw now because you said these words. And I can now solve the problem. You can't solve the problem, but because of the words that you've used, now I know how to solve the problem. Sounds like the first rule of a design program in a medical school is that there is no such thing as a design program at the medical school. It's something else entirely.
That is actually what I always say in a little stump speech if I'm asked to come ask, hey, how could we get this started at my school? And my pause for laughter moment is the first rule of getting a design thinking started at your school is not to say you're trying to do design thinking. And you already heard my pitch. It's to start with an existing pain point, tie it to a national agenda, and then also look for existing curriculum, where there's already something in the curriculum, and then just show that design thinking can really add value to it. Because there's usually going to be something like social issues in medicine, or there's going to be something even just pure patient interviewing, or kind of innovation type courses. There's usually some place where you can put it, and you don't have to make a huge deal about it. Because I do feel when you say design thinking, people they hone in on the graphic design kind of mindset, and you're like, oh, well, I mean, graphics. Don't get me started. Graphic design actually is a bigger deal than you think. But no, I'm actually talking about kind of a core set of a structured approach to like keeping yourself in a mindset of learning about users of a product or service that have a different lived experience than you. That sounds valuable, right? Like, isn't that what we're all supposed to be doing as doctors? Actually, yeah, that does sound good. And you're like, cool. Well, I'm also going to do a structured approach to like, keeping yourself in a learning mindset as opposed to going right to the first solution that comes to your mind. Doesn't that sound like a good thing we should all be doing as clinicians? Yeah, this actually sounds really good.
What about those docs who are out for a decade or two? Have you approached that kind of a group? Are they interested in learning about this, or are they old dogs that are not interested in new tricks?
No, I think there's a lot of interest in that, and that is something we're exploring. I'm exploring both within my role at UVA and developing kind of other types of digital content, because I think this is particularly relevant in the era of AI. I recently launched the classic version of my design program is for first year medical students, which I just really enjoy. But now I'm doing a fourth year elective, which is a lot of fun. It often ends up being alumni of my first year, but now they're bringing clinical ideas. But I've renamed that one Health Design Thinking and Building, because I think what AI does that solves a big problem in this kind of teaching is you can prototype things so much faster, because that's actually that ends up being the hardest thing to do. Like a classic design studio, right, is like in an architecture school or something, is like you live and breathe this in a studio for like a whole semester and stay up all night and just constantly, because as again, my friend Dina has been very seminal in my career, she's a good dear friend. She always talked about that real design is the unsexy middle bits. It's the endless iteration on things. It's the hard work of creating stuff. And so we don't get to do enough of that in the design program. In the elective, we're going to do a little more, but AI helps you. Now there's really no excuse not to let's build a quick digital prototype of something. Well, it doesn't have to take a month. You can get a pretty significant workshop done in a day or even less. So yeah, I'm starting with the fourth year students, but I think again, there is no time at which this isn't something you can pick up and learn and make, the day-to-day practice of medicine and healthcare more fun and I think more effective.
I love your perspective of kind of just leveraging AI to prototype things much faster. And even if it only works a little, I mean, I've seen, I think it's called vibe coding, right? I don't really understand how to program, but I told it what I wanted to do and I have no idea how it's doing it, but it seems to be doing it. And even though that's, you're not going to start a company that way with that kind of software. You have something that you can show to people and get feedback. And yeah, that's something I would love,
That's the thing. Yes, you can definitely jump into vibe coding things like Cursor and stuff. But as you said, honestly, like using programs like Figma and stuff like that, where in the context of a design sprint, actually just getting like a workable, clickable prototype of the front end that just kind of gets people thinking about what might happen. You're kind of more of a Wizard of Oz type prototype. That can be more than enough. And that is suddenly in the realm of easy possibility within a course. And I think that's really empowering to students. Like part of my goal of these courses is to like, not just sell them on a big thing, but leave them with like extremely tangible little like workshops they can run. A lot of the things I do are designed to be very easily picked up and used again by a student after they've been used once. And so that's why I'm very excited and just getting started really developing coursework that really leverages AI. A lot of what we trade back and forth is like, how do you rapidly distill down the concepts of human-centered design thinking for a medical education audience where time is always too little. And at any point, the dean of the medical school could walk in and be like, what's going on here? Is this clinically relevant? And so and also the students themselves, I always warn people, I'm like, there is nothing more like intense about protecting time than a med student. They can sense if they're not extracting maximum value out of this time they're with you, they're out. So you've got to deliver them a 2-hour workshop that teaches them something new Doesn't take too much prep work. I try my best, It's a lot of fun to try to take up that challenge.
I'm tired just contemplating all the work that you're doing and keeping up with those young medical students. We are almost out of time, and we always like to end with the same question. And as someone that teaches design, this is a great question for you. And here's the question. What is something that's so well designed that you use that brings you joy whenever you interact with it?
Before, about a week ago, it would have been my Waterfield black backpack that I've had for about 10 years, because it's just, it never breaks. And it's like all the pockets are just the right size for everything. And it looks better the more it gets used. So that's one thing. But I bought a new electric bike. It's a specialized Globe Haul short tail. And what I love about it is I'm a huge cyclist, but what I love about this bike, particular to your question, is it knows exactly what its role is. It has a point of view. It's heavy. It's not the most nimble, but it can carry like 400 pounds of cargo if you need to. So it's super stable. If you hit bumps, it doesn't care. And it makes every day, like I live about 2 miles or so from the university. And that one bike means that now when I load up all my supplies for design, I don't have to drive. And now suddenly I get this little 10-minute bike ride right into the center of university. And I don't know, it's like, you pull up, it's got this burly kickstand, boom. Every single part of it is like, I am a cargo bike. That is what I am. And I love that about it.
Well, that's great. What fun it has been to talk with you, a real leader in design and healthcare. So impressed by the work that you're doing. Can't wait to see it. I want to sign up. I'm thinking of going back to medical school at UVA. So I might just re-enroll just so I can take your class. I'm not sure how UVA would feel about that.
We'd welcome you with open arms.
Well, thank you so much. I feel like there's another show coming. We could interview you about a bunch of other topics, and I think we'll do that. But I'll let you off the hook for right now and say, again, thank you so much. Really appreciate it.
Thank you for having me. And I really appreciate what you're doing with this podcast. I genuinely believe that design offers something that brings a lot of joy to practice, but that it also has a real set of skills that can really advance healthcare.
Well, that's two of us that believe that. Thanks for tuning in. We hope you enjoyed today's episode. For more on Dr. Trowbridge, find him on LinkedIn. Check back for more episodes of Designing for Health wherever you listen to podcasts, or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.